post-surgical patients. The PACU nurse receives a verbal report from the anesthesia care provider about the procedure, the blood loss, the anesthesia that was administered, the fluids that were infused, the medications that were provided, and any problems that occurred during the procedure. The patient is immediately attached to the cardiac monitors and the pulse oximetry monitor, and oxygen is routinely administered if the patient had general anesthesia. An oral airway, laryngeal mask airway, or an endotracheal tube may still be in place because the anesthesia medications relax the tongue enough to occlude the airway, and the patient may not be fully awake enough to remove the airway device. Surgical recovery may take from 1 to 6 hours. Time of stay in the PACU is determined by the operative procedure and the type of anesthetic that was used. The nurse will assess for the return of the gag reflex by determining whether or not the patient can swallow their secretions. Anesthesia uses the Aldrete Scoring to determine the patient's eligibility for transfer. Assessment of the patient is performed at least every 15 minutes or accordingly to the status of the patient. Assessment for complications of the procedure and anesthesia are ongoing. A form of Aldrete Scoring system is used to determine the readiness for transfer. Activity, respiration, circulation, consciousness, skin color, and oxygen saturation are all provided with a score. A patient with a score of 9 to 10 is ready for transfer to the nursing unit. Airway, breathing, and circulation are always the nurse's first thought when caring for a post-operative patient. After a couple of hours, the vital sign measurement can be assigned to a UAP that is proficient in obtaining accurate measurements. The unlicensed assistive personnel does need to be reminded of what is exactly necessary to report. Any temperature that is elevated above 99.8, the blood pressure alteration of a specific amount, whether it is down or up from the baseline, tachycardia, and respiratory rate that are above or below the patient's normal range. Maintaining a patent airway for the patient is always a top priority measure to promote oxygenation and ventilation. Unless it is contraindicated, the patient will be positioned on the side or with the head turned to the side to prevent any aspiration until they have fully recovered, are alert, and they have a gag reflex intact. A varied degree of atelectasis, or collapse of the alveoli in the lungs, exists after anesthesia. A mild hypoxia is usually present for about 48 hours after surgery. If any of the lung remains atelectic for more than 72 hours, hypostatic pneumonia from the retained secretions probably will occur. A low-grade fever in the first 24 to 48 hours often indicates atelectasis. Hypostatic pneumonia will result when there is a lack of movement or position change that causes any stasis of secretion in the lungs. This becomes a breeding ground for bacteria. The nurse must auscultate the lungs carefully for abnormal sounds that indicate any retained secretions, assess the rate and depth of respirations, and encourage the patient to deep breathe and cough every 2 hours to promote airway clearance. The nurse should ensure that the patient turns every 2 hours. This will change the distribution of the gases and the blood flow in the lungs and will help move the secretions. Early ambulation of the postoperative patient is ordered to assist in promoting ventilation. The Joint Commission core measures require antithrombosis therapy after most surgeries. Blood pressure and pulse should be compared with preoperative values to determine whether there are significant changes. An increase in pulse may indicate internal bleeding is occurring, but it can also signify incomplete pain control. Blood pressure that falls below the patient's baseline may indicate major bleeding. The use of sequential compression devices, or SCDs, on the legs is recommended. SCDs alternately compress and release, squeezing the lower legs and propelling the blood along the vessels. This will increase the venous return from the legs and help prevent stasis of blood in the lower extremities. Safety is a primary concern for the nurse until the patient is fully recovered from the anesthetic. One of the known risk factors for falls is opioid medications. The nurse should encourage the patient to increase fluids, including those that contain caffeine. Fluids and caffeine will raise the vascular pressure at the spinal puncture site and to help seal a hole if the patient has had spinal anesthesia. Urine output is continuously monitored after surgery. If the patient has an indwelling catheter, the urine will be observed in the bag every hour in the early postoperative period. A urine flow of less than 30 milliliters per hour must be reported to the charge nurse. A patient that does not have an indwelling catheter must void within 4 to 8 hours, depending on the type of surgery and the anesthetic that is used. If the patient is unable to empty the bladder spontaneously, the nurse should obtain a bladder scan and, if needed, ask the physician for an order for catheterization. If the urine flow is less than 60 milliliters over a 2-hour period, the surgeon must be notified. No potassium additives should be given until the urine flow rate is at least 30 milliliters per hour, because potassium may cause hyperkalemia if the kidney function is not adequate. Remember that 1 cup of ice equals a half a cup of water. When an NG tube is in place, the nurse should check that it is positioned and functioning appropriately, and that the suction is set according to the provider's orders. The nurse should assess the amount of drainage produced every 1 to 2 hours. If the drainage turns dark brown and grainy, it should be checked for blood using a special reagent. After surgery that has required a general anesthetic, the patient will not be allowed to eat solid foods until bowel sounds have returned because of the risk of developing a paralytic ileus. Suppositories or laxatives may be necessary to stimulate a bowel movement. Patients that have received narcotic analgesics may become constipated and require stool softeners or laxatives to produce routine bowel movements. Gas buildup in the abdominal area will provide pressure on the abdomen and promote pain and discomfort for the patient. The patient's pain level and the effectiveness of any analgesia using a pain scale should be assessed every 2 to 3 hours. Non-steroidal anti-inflammatory medications and non-narcotic analgesics both work on the peripheral nervous system and the central nervous system to control pain and may be used to augment opioid medications. Medications should be consistently given for the first 24 to 48 hours postoperatively. The patient's pain level should be assessed minimally every 2 to 3 hours. The Joint Commission's core measures specifically state the importance of warming a patient after undergoing colon surgery. By placing socks on the patient's feet, this may help the patient to warm faster. Any opioid medications have the potential to depress and decrease the respiratory rate as well as the cough and gag reflex. By keeping blood from pooling in the lower extremities helps to prevent a thrombus formation or an embolus, which is a thrombus that has traveled and lodges elsewhere in the body. By continuing to ambulate the patient in the hospital or at home and on a set schedule, the patient will be more likely to decrease the risk of blood pooling. The phases of primary intention wound healing are phase 1, the acute inflammatory reaction, which occurs in the first 3 to 4 days. This is a process of homeostasis where the blood vessels constrict, the platelets aggregate, and there is a formation of fibrin and epithelial cell migration. Phagocytosis occurs and a scab forms. In phase 2, there is a proliferation and granulation from day 3 or 4 to 3 to 4 weeks after. Macrophages clear debris, fibroblasts synthesize collagen, capillary networks are built, and granulation tissue is formed. Closure by contracture begins. For phase 3, there is a scar maturation and contracture within 3 to 6 weeks. Remodeling with collagen lysis and synthesis occurs, and scar tissue thins and becomes paler but stronger. To promote healthy healing, individuals need foods that are high in vitamin C and protein. Foods high in vitamin C will be citrus, fruits and juices, strawberries, cantaloupe, tomatoes, bell peppers, cabbage, broccoli, peaches, pineapple, or potatoes. Foods high in protein: any meat, chicken, beef, pork, or lamb, cottage cheese, milk, cheese, peanut butter, eggs, beans, ice cream, grain products such as bread or pasta, and tofu, which is a soy product. Excessive stress, apprehension, and emotional disturbance make the body more vulnerable to invasion by foreign organisms by depressing the immune system. Assessment includes observing the incision line for signs of excessive swelling, formation of a hematoma, a formation of a seroma, redness or tearing of the skins, or other signs of separation of the edges of skin that have been sutured or stapled together. The nurse should report and document any evidence of bleeding, purulence, or any sign that the wound is not healing properly. The nurse should document the appearance of any drainage. Drainage can be serous, serosanguinous, or sanguinous. The surgical dressing should be checked each time vital signs are taken for the first 24 hours after surgery, every 4 hours during the next 24 hours, and then minimally every 8 hours for as long as the surgical wound is covered with the original dressing. The surgeon routinely does the first dressing change to view the incision site. If the dressing becomes saturated before that dressing change, the nurse should reinforce the dressing by placing more dressing material over the areas. To reactivate a surgical wound suction device, this is done by compressing the suction after emptying the reservoir. If an infection is going to develop, routinely it becomes apparent in 2 to 7 days postoperatively. Subjective complaints that may indicate infection would include fatigue, a loss of appetite, headache, nausea, malaise, or pain. Objective signs or symptoms will include pain, redness, swelling, induration in the area, purulent drainage, fever, increased pulse rate, elevated white blood cell count, and swollen lymph nodes within the adjacent areas. Dehiscence may occur at any time during the postoperative period, but it most oftenly occurs between the 5th and 12th postoperative day. This is when the patient is feeling stronger and more active, but healing is not complete or infection may have occurred. When assessing an abdominal surgical wound, the nurse should be aware of any drainage. There is often a noticeable increase in the amount of serosanguinous drainage before the separation of the wound layers actually becomes apparent. Subjectively, the patient may not notice any symptoms until they state they have a feeling of giving away in the wound. Patients most at risk for dehiscence and evisceration are those who are diabetic, obese, malnourished, or dehydrated, have malignancy, have experienced multiple traumas to the abdomen, or have an infected wound. Evisceration, this creates an emergency that requires immediate surgery and is a very serious complication. The immediate treatment for evisceration before reparative surgery includes having the patient lie in supine position with the knees flexed. The wound should be covered with sterile towels or sterile saline moistened dressing. Early signs of impending hypovolemic shock from hemorrhage are thirst, restlessness, tachycardia, and tachypnea. Changes in vital signs may be the only warning sign of shock. As shock progresses, the blood pressure begins to drop and the pulse rate will increase. Malignant hypothermia occurs from a biochemical reaction in the body for individuals that have genetically predisposed situations. Material for home care for post-surgical patients. The patient should know about each medication to be taken, when they should take it, and what side effects to be mindful for, and are they able to obtain the medications. The patient should understand their diet, any restrictions, and guidelines for fluid intake. The patient should understand that alcohol must be avoided for 24 hours after surgery and while taking any opioid for pain management. The patient should verbalize restrictions on activity and instructions for use of any special equipment like crutches, splint, and walker. The patient should understand that they are not to drive or make important decisions for 24 hours after receiving an anesthetic. The patient should verbalize the type of bath that they are permitted and how to best protect their wound. The patient should be able to demonstrate cleansing and dressing of their wound and verbalize where they should obtain supplies. The patient should verbalize signs and symptoms that must be reported to the surgeon. The patient should understand how to schedule a follow-up appointment with the surgeon. And the patient should understand any written instructions for essential points of care and consultation. With same-day surgery and early release from the hospital after inpatient surgery, it is vital that the nurse start discharge planning on admission or several days prior to the surgery date. There are various precautions related to the individual who has had any anesthetic. Should not drive for 24 hours. Various medication interactions. If they're taking opioids, the potential for constipation.